Hello, my name is Yuni Susanti Pratiwi. I am from Physiology Division, Biomedical Science Department, and today we are going to discuss together about exercise and reproductive function. So I would like to use English in this occasion because I want to also discuss with our another international students. So again, like my previous discussion, so this is only the introduction lecture, and I will leave a void for you all to explore for yourself. So I'm giving you introduction to many important or distinguished research about this, and maybe the opportunity or the potential. You can ask yourself what's next and what we can do more about it if you're interested with these um, topics. Also, I think this is very sexy topics and still a lot of that we can do about this. Uh, of course, for our health or for the athlete performance. So this is a very open topics, and then you can have later on enjoyable self-study session. But in this occasion also I will go deeper more to the female reproductive system rather than the male reproductive system. So maybe you can do more self-research about the male reproductive function that affected by the exercise. So we're studying now from the female reproductive system. So just keep in mind that we will talk this, just go back from one to another, from the community health and also the athlete performance. So the exercise effect for the just like sedentary people or non-athlete, and also the exercise effect to the athlete, right? So, the benefit of exercise that is fundamental to prevent the risk of cardiovascular disease, diabetes mellitus, to impact on reproductive function, and this is the most acclaimed finding about exercise effect that found to be decrease the risk of the breast cancer. So, regular physical activity is associated with a decrease in the risk of postmenopausal breast cancer. One of the proposed mechanisms for this association is a reduction in circulating levels of reproductive hormones, specifically estrogen and androgens, which are widely accepted to be etiologically linked to the postmenopausal breast cancer as well as endometrial and ovarian cancer. So let's just go deeper on what is the difference between the postmenopausal breast cancer and the premenopausal breast cancer. So it is reasonable to hypothesize that premenopausal endogenous reproductive hormone exposure may be associated with the risk for postmenopausal breast cancer and other hormonally related cancer by inducing increases in the cellular proliferation rate in the breast and other reproductive tissue. However, there are important differences in the mechanism by which reproductive hormones are formed in the premenopausal versus postmenopausal women. So, levels of circulating hormones in the postmenopausal women are determined by adrenal activity and conversion of testosterone and androstenedione to estrone in their adipose tissue. So physical activity actually reduces body fat, and after the menopausal transition, the body fat becomes important to determining endogenous estrogen and androgen levels. So physical activity has been shown to decrease estrogens and androgens in association with the reduced body fat in postmenopausal women. So actually disease in this slide that actually can possible give effect to the because the physical activity actually reduce the body fat. Um, Conversely, in the premenopausal women, ovarian hormone production predominates, at least for estrogens, and the circulating levels are less influenced by adipose tissue. The relative balance of ovarian versus adrenal production of androgens is as yet unclear, although there is evidence of significant testosterone production by the ovaries even after menopause. So physical activity may alter endogenous hormone exposure through differing mechanism among premenopausal versus postmenopausal women. But furthermore, during the menopausal transition, there is a gradual shift away from the predominance of ovarian estrogen production. Circulating reproductive hormone levels may be increasingly influenced by body fat as women progress through the menopausal transition. This may mean that physical activity through alteration in body fat may become increasingly important to determining circulating reproductive hormone level across the menopausal transition. If physical activity does influence endogenous reproductive hormones among perimenopausal women in a manner that would be consistent with the reduction of breast cancer risk, so this may represent a new window of opportunity for intervention. So, um, I would like to also um, to introduce you with this famous study. It is called the Pan Ovarian Aging Study. So few studies have directly examined the role of physical activity on hormones, but none have examined the potential effect of the menopausal transition on this association. In this report, data from the Pan Ovarian Aging Study is to have objective to explore the potential for self-reported leisure time physical activity to influence circulating hormone levels across the menopausal transition. The prior hypothesis of this study was that inverse association of physical activity with circulating reproductive hormone levels would become increasingly apparent as women progress through the menopausal transition stage, as the ovaries decrease production of the same hormones. So the hypothesis assumed that the body fat plays an increasing role in determining circulating reproductive hormones as women transfers the menopause, and the physical activity will become increasingly associated with reproductive hormones across menopausal transition for this reason. To more completely explore this hypothesis, they also undertake analysis to explore whether an observed association of physical activity and reproductive hormones might differ by body size. Physical activity, they found that the physical activity more than 1,455 kilocalorie per week was associated with 54% and 47% lower estradiol and testosterone levels, respectively, among women in the late transition phase of the menopausal transition, as defined by 3 to 11 months of amenorrhea. So, although not statistically significant, estradiol and testosterone were observed to be 19% and 15% lower, respectively, among postmenopausal women who were in the highest versus lowest physical activity tertile. It is possible that the reason an association was detected among late transition but not postmenopausal women was that hormone levels were higher among women in the late transition phase. On the other hand, it could be that physical activity has the potential to reduce endogenous estrogens and androgens in a specific window of time late in the menopausal transition time period. It is also possible that the association detected among the late transition period were due to change. So, physical activity has been shown to be inversely associated with estrogen levels among postmenopausal women in some, but not all, in the observational study. So, six cross-sectional studies also have examined the association between exercise and the hormone levels within postmenopausal women. Of these six studies, the three studies observed lower estradiol or estrogen levels among women who self-reported higher levels of physical activity. But none of the three studies that specifically examined association of physical activity with testosterone has been like designed to be randomized control trial and just like a cross-sectional study. So, in addition, there has been one randomized control trial that has examined the effect of exercise on the estrogen and androgens in postmenopausal women. The study included 173 postmenopausal women who were randomized to a treatment or control group. The physical activity intervention group consisted at least 45 minutes of moderate intensity sports or recreational activity 5 days a week for 12 months. The study showed that significant reduction in serum estradiol, estrogen, and testosterone were noted at 3 months. At 12 months, these results were no longer significant, except among women who had lost more than 2% body fat. Overall, observational studies and one experimental study have observed quite a mixed result, with regard to the association of physical activity in determining sex hormones after menopause. So, maybe we can hypothesize that any observed association between physical activity and endogenous reproductive hormones among perimenopausal women would be affected by body size. So the present data partly support this hypothesis given our observation that differences in testosterone by physical activity was most evident among women with the highest BMI category of more than 30. So this result and the findings from McTiernan and Coley et al. All concur that body size is an important variable to consider in the association of physical activity with endogenous estrogens and androgens. The relative importance of ovarian versus adipose tissue production of reproductive hormone shifts during the menopausal transition. Physical activity is thought to primarily influence hormonal activity through the alteration in energy balance or body fat levels. Many findings also show a significant association between physical activity and hormone levels after uh, 3 until 11 months of amenorrhea. So therefore, it is possible that the shift from the ovarian to adipose production of hormones may occur before 12 months of amenorrhea. So the currently accepted definition of postmenopause. Okay. Um. So yeah. While moderate, we're talking about the moderate exercise now. That from this figure, we also know that the moderate exercise provide benefits for the health of women who participate in sport. It has been demonstrated that there is a risk associated with the intense physical exercise, especially for female athletes. These risks are defined as the female athlete triad, right? Comprising for amenorrhea, osteoporosis, and eating disorder. I'm sorry. So several studies have demonstrated both the positive and negative effect of physical exercise actually are related to the hypothalamic pituitary ovarian axis and the hormones such as LH, FSH, estriol, progesterone that's secreted from this system as the pathway of the female reproductive system. The pulsatile mode of gonadotropin releasing hormone release, it is important for sustained physiological function of gonadotrope cells as the reproductive system function, and it is demonstrated that inadequate nutrient intake and stress may impair the release of gonadotropic hormones. Furthermore, several authors have documented the impact of the menstrual cycle on exercise performance and concluded that there is not significant difference in athletic performance during menstrual cycle. Other authors, however, have demonstrated that all phases of menstrual cycle have modulating effects on the ventilatory response to the physical exercise that may be altered under acute hypobaric hypoxic condition. There are many solutions to the amenorrhea if happen on the female athletes, including recommendation of a diet rich in vitamin and minerals, as well as another solution of oral contraceptive. Okay, and we also know that the menstrual cycle um, is a physiological event that begins during a female's youth and occurs monthly, approximately every 28 days. The hypothalamic pituitary ovarian axis coordinate this cycle, and the physiological and the pathological alteration that could occur in the life of women influence its presence. The hypothalamic neurovascular terminus release gonadotropin releasing hormone that is the primary determinant of secretion of pulsatile gonadotropin ratio and LH and the FSH. The gonadotropin releasing hormone is transported to the pituitary gland through the hypothalamic hypophyseal portal microcirculatory system and drive the synchronize among the hypothalamus, anterior pituitary gland, and the gonads. So actually the pulsatile secretion of LH and FSH is modulated by the intrapituitary and systemic feedback signal. So the menstrual cycle is characterized by the change in the blood of many hormones during the different phases of menstrual cycle. The main phases of the menstrual cycle can be reassumed in the follicular and luteal phases, while the most important hormone involving are the gonadotropin luteinizing hormone LH, follicle stimulating hormone FSH, gonadal steroid hormone estradiol A2, and progesterone. The plasmatic level of A2 and the progesterone are low in the follicular phase while they are increased during the luteal phase. The main effect of the estradiol and progesterone is related to the reproductive function, but they have effect on the energy substrate metabolism, thermoregulation, and body water and electrolyte homeostasis too. So there is an increase in LH secretory pulse frequency during the later follicular phase and the preovulatory interval, and a decrease of its level in mid-luteal phase. The pulsatile LH signal in the follicular and luteal phase regulates the production of steroid hormone and progesterone by the ovary. In the late follicular phase, there is an association between LH pulse and estradiol peaks in the blood, And in the mid-luteal phase of the menstrual cycle, there is a coordinated release of the LH and A2 with increases and decreases in concentration of the sex hormone. LH and FSH support long-term luteal steroidogenesis and short-term increases in secretion of the progesterone or estradiol. So it is known that, however, that women with type 1 diabetes also experience a decrease of sexual function and an increase in sexual distress during the luteal but not in the follicular phase. So this is really interesting, right? So the sex steroid hormones of women have multiple action on body system other than reproductive axis. Estrogen and progesterone have potential effect on the exercise capacity and performance through numerous mechanisms such as substrate metabolism, cardiorespiratory function, thermoregulation, and also the psychological factors. So estrogen affects the cardiovascular system and bone, and progesterone primarily influences thermoregulation and ventilation. Both hormones act on substrate metabolism. So it has been demonstrated that exercise is associated with decline in the concentration of LH and with a normal secretion of FSH. Indeed, the hormonal profile of women engaged in sport is characterized by hypoestrogenism, resulting from suppression of the hypothalamic pulsatile release of gonadotropin-releasing hormone. The effects of estradiol and progesterone on energy substrate metabolism, thermoregulation, body water, and electrolyte homeostasis are fundamental functions in the exercise status, and they could have a role on both exercise capacity and performance. In the mid-luteal phase, the level of progesterone increased through it did not increase in the stimulating minute ventilation, neither affected the performance or other exercise at the sea level or the acute altitude. So, an author, Lebrun et al., demonstrated a 2% lower VO2 max in the mid-luteal phase than the early follicular phase, whereas other authors reported a 13% reduction in the VO2 max after 4 months of oral contraceptive use. On the contrary, those people who live at the high altitudes have higher VO2 max in the luteal phase than the follicular phase. So mostly due to the increase the oxygen saturation that is caused by increase of respiratory drive in the luteal phase. Therefore, women who are acutely exposed to altitude did not show this compensatory mechanism. But nevertheless, it has been reported that athletes with amenorrheic women increase respiratory drive in order to achieve maximal exercise in high altitude thanks for the progesterone in the luteal phase. Another author, Son et al., have demonstrated that the higher respiratory drive in the luteal phase will blunt maximal exercise performance in non-athletes because it can increase in dyspnea. In fact, the asthmatic athletes experience more severe bronchoconstriction during physical activity in the mid-luteal phase than the mid-follicular phase. So this is really interesting, right? That our respiratory system can also be affected with this menstrual cycle. Okay, so however, it has been demonstrated the menstrual phase did not influence the exercise intensity that causes the point of inflection corresponding to the lactate or ventilatory threshold. Some study reported that early follicular phase is associated with a ventilatory threshold that happens at a higher percentage of VO2 max in the late follicular and mid-luteal phases. But conversely, other studies demonstrate that lactate threshold is activated later in the luteal phase compared to follicular phase. So in the same way, other authors also have demonstrated that the blood lactate concentration during physical activity are lower in the luteal phase than the follicular phase, although other authors argue to opposite. So Moreover, muscle strength along with performances during physical exercise improve during menstruation. So this may be related to the different hormonal status in the influence the substrate metabolism during physical activity, resulting in a different muscle strength and physical performance. The administration of estrogen has been associated with a shift in the triglyceride fatty acid flux from the adipose tissue to the storage into the muscle at rest, thus suggesting that estrogen influences both the synthesis and the storage of the fatty acid. Okay, so actually, there is no evidence that an adequate physical exercise will be dangerous to the reproductive system of women, but rather evidence of whole body benefits. So, indeed, the attention of the research group is on the effect of intense exercise because it induces endocrine pathology acting on the normal function of HPA axis. So it is known that the reproductive system of women is very sensitive to physiological stress, as with the strenuous exercise. So indeed, yes, the female athlete triad has a high possibility of pathology about the reproductive system as primary or secondary amenorrhea and oligomenorrhea. In October 2007, a group of authors published a position stand on the divulge the current state of knowledge about the female athlete triad and to show guideline to the treatment. The authors um, also define the female athlete triad as interrelationship among energy availability, menstrual function, and bone mass density and its clinical manifestation are eating disorder, functional hypothalamic amenorrhea, and osteoporosis. So from this study in 2003, um, we can know that this study highlight the importance for further research in this area where our menstrual cycles length prediction and timing of exercise testing days and the basal hormone concentration are better controlled. So, hormone manipulation of the menstrual cycle via the oral contraceptive pill may provide one solution. So, under these circumstances, the ratio between synthetic estradiol and progesterone can be pharmacologically manipulated to explore the single and couple effect of the female sex steroid on substrate selection and exercise performance with more precision. So the consequences of female athlete triad include short-term, such as infertility, and long-term, such as um, osteoporosis. A consequence. In women athletes, there is a decrease in secretion of gonadotropin-releasing hormone that limits the pituitary to secrete LH and FSH, which in turn shut down the stimulation of the to the ovary kiss, because of they want to cease production of estradiol. So the range of abnormality is very broad, including a decrease of frequency and amplitude of pulse to a pattern of sporadic pulses or nocturnal entrainment of the LH pulse. This is a prolonged follicular phase or the absence of critical LH and estradiol surge, and low LH level in the female athletes also responsible for delayed menarche or primary and secondary amenorrhea. So the hormone profile of female athletes that necessity low weight, so the athlete with the really low body weight, such as ballet, dancing, long distance running, gymnastic, and figure skating, is characterized by the hypoestrogenism resulting from the suppression of the pulsatility of gonadotropic releasing hormone. So this suppression affects the normal secretion of LH, which result in a decrease of FSH level and thus a decrease in the production of estradiol. So in the women athletes, the results are a prolonged follicular phase or the abnormal follicular or the absence of LH or estradiol mid-cycle, which take the suppression of menstrual cycle. The excessive physical exercise is interpreted by the body like a condition of stress and affect the secretion of the neuroendocrine modulators, with important alteration on excitation of numerous factors inducing a hypogonadism. So, in particular, there is a decrease of gonadotropin levels, an increase of levels of prolactin, growth hormone, adrenocorticotropin hormone, glucocorticoid, and endorphins. It also includes a state of deep hypoestrogenism due to short ovarian functionality with important repercussion on bone metabolism. In fact, the hypoestrogenic athlete is predisposed to osteoporosis and osteopenia with increased risk to develop scoliosis and the bone fracture. The level of free androgens is increased as consequence of condition of the estrogenic deficit and the reduction the level of estradiol. So other than that, the levels of thyroid hormone like thyroid stimulating hormone, free thyroid 3 and free thyroid 4 are also decreased. So furthermore, um, these athletes also present low levels of leptin, that is a hormone produced in the adipose tissue, which is increased for the reduction of fatty mass. The protection of the stress in this woman also activates hypothalamus pituitary adrenal gland axis, that giving rise to a consequent high level of cortisol. So, in the inadequate diet delay create disruption of the pubertal development of the reproductive system and also the function of the hypothalamic pituitary gonadal axis in an adult. So the malnutrition affects level of gonadotropin releasing hormone, which are decreased, and this causes a decrease of gonadotropin levels. So energy availability is defined as dietary energy intake minus exercise energy expenditure. So negative energy availability is the primary cause of the impaired normal reproductive function and skeletal health of female athletes, and it may be inadvertent, intentional, or psychopathological. So exercise can be a factor that causes premenopausal osteoporosis. So strenuous exercise or heavily exercise cause hypercortisolism, hypogonadism, and nutritional depletion, which include inadequate calcium and the vitamin D intake. So during adolescence, there is a rapid skeletal growth to adult side. This period influences on the peak bone mass, augmenting or reducing the risk of the osteoporosis. So peak bone mass is influenced by the IGF-1, which regulates skeletal growth, and the extra sorry which regulate the skeletal growth, sex steroid, which stimulate epiphyseal maturation, and those factors are diminished in athletes. So interleukin 6 has a role in skeletal homeostasis, and during exercise its secretion is increased. So interleukin 6 may be implicated in the pathogenesis of the osteoporosis. So, of a female athlete's bone mass density is best described as a single snapshot of her cumulative bone health at any point in time based on many interrelated variables such as energy availability, menstrual function, and the genetic influence. So, since the majority of the peak bone mass is occur in the childhood and adolescence, it is very vital that at-risk athletes has been identified in attempt to prevent the chronic poor bone health. Okay, it is uh, it is also known that infertility in obese people is mostly due to the body weight that plays a key role in the development of reproductive role in the development of reproductive function. So the excess of fat support increase of estrogen levels for increase of a peripheral conversion of androstenedione to the estrone. So actually, physical activity improve insulin sensitivity at skeletal muscle, increasing glucose uptake and reducing intramuscular lipid concentration. So here now we are talking, if previously we are talking about how strenuous exercise of intensive exercise can do harm to a female health, but in the moderate portion, it can give a benefit for the female reproductive age. So the benefits of exercise consist of reduction the visceral fat, resulting in an improvement of several metabolic parameters and the blood pressure. The contribution of regular and moderate activity, such as participation in high school athletic program, is very favorable. It has been demonstrated that these athletic participants have denser hip and spine bones compared to with sedentary controls. Adolescent female athletics participants have also reduced a risk of future fracture as well. So physical activity program for young women have a favorable impact to possible pregnancy. Regulate moderate exercise is recommended in the pregnant woman through there are alteration the fitness capability. Potential dangers to the fetus include excessive rise of core body temperature, a decrease of material blood sugar, and the fetal hypoxia. So other positive effect of moderate physical activity are an increase in the strength and endurance, improved cognitive function, neuromuscular coordination, physical appearance, and the potential to elicit of the sense of well-being. So these are the positive effect that often contribute to higher quality of life of the athletes. So in the prospective study about the effect of exercise training on the premenstrual distress and ovarian state hormone, the study showed that exercise reduced the global symptom score of premenstrual stress and levels of the hormone of the late luteal phase of the menstrual cycle. The premenstrual syndrome disorder includes water retention, painful breast, anxiety, skin disorder, irritability, cramps, mood swing, sleepiness, backache, depression, and tension. And it has been demonstrated that women who frequently exercise may be protected from deterioration of mood before and during the premenstrual cycle. And the physical exercise is also known have associated with a decreased risk for the breast cancer. The physical activity may protect the postmenopausal women because reduced lifetime exposure to endogenous hormones either directly or indirect by preventing overweight and abdominal adiposity. So many studies have shown that physically active women have a lower risk of breast cancer than inactive women. In 2016, there are meta-analyses that include 38 cohort study. The most physically active women have a 12 until 20% lower risk of breast cancer than those who were less physically active. So physically active has been associated with a similar reduction in the risk of breast cancer among the both premenopausal and postmenopausal women. So women who increase their physical activity after menopause may also have a lower risk of breast cancer than women who do not. So the polycystic ovary syndrome is a common endocrinopathy affecting 5 until 10% of women of a reproductive age, and obesity has a high percent of occurrence in patients with polycystic ovary syndrome or PCOS. Uh, and it is represent an important factor increasing its clinic evolution both in metabolic and reproductive term. So structures exercise training programs and a diet higher in proteins and lower in carbohydrates is the first line therapeutic approach in those patients. So regular physical activity is an important component of weight loss program in the patient with the PCOS, considering the possible orthopedic and cardiovascular limitation. So a modest weight loss due to energy restriction has been reported to improve the cardiovascular factors, hormonal stages, and reproductive function in overweight and obese women with the PCOS. Okay, and then the next slide, we want to move to the male reproductive section. And again, like I said before, will not go deeper in this section because I want to leave you with your life study session. So issues in male is evidence suggests exercise associated reproductive disorder occur in men, especially in those athletes competing in endurance and weight dependent sports. So alteration in total and free testosterone levels are frequently reported in male athletes. For example, in a study of young wrestlers, significantly fluctuation in testosterone levels coincided with the striking changes in dietary intake and body composition. Another study told us that the training intervals that coincided with the severe energy restriction resulted in a decline in testosterone to levels well below the normal range for men, whereas training intervals with the normal feeding produced a prompt recovery in the testosterone level even though the physiological stressors persisted. So therefore, the energy deficit, not the exercise per se, was associated with the decline of testosterone. Therefore, although endurance training suppresses testosterone levels in men, it is safe to say that the training will not lead to the clinical concern for most male athletes. Significant reduction in testosterone level are probably only evident in extreme situations of energy deficit created by high volume of physical activity combined with the severe energy restriction. So one issue in male is erectile dysfunction. So a number of studies have reported the positive association between the bicycle riding and erectile dysfunction. The incidence of erectile dysfunction in cyclists range from 4% in amateur riders to 24% in the professional whose training exceeded 400 km per week, whereas in comparison, the incidence of erectile dysfunction in swimmers is only 2%. So the mechanism of erectile dysfunction in cycling have been linked to the perennial vascular trauma and age over 50 years and other comorbidity rather than a direct association with the training volume or energy deficit. Another issue in male is the spermatogenesis. So there is some evidence to suggest that males with a high level of physical activity may have some impairment of fertility. In the survey of artificial insemination donors, a high level of physical activity was associated with low semen volume and lower pregnancy rates, and additionally, in vitro sperm penetration of the cervical mucus has been reported to be lower in the highly trained runners. So several modifications in semen profiles have been reported in the athletes, and total sperm count and semen volume appear normal even with the extreme training volumes. So however, sperm morphology and the sperm motility are often reported to be abnormal. So a recent investigation in the competitive distance cyclists found that the proportion of spermatozoa with the abnormal morphology was twofold higher compared with a group of age-matched sedentary controls. In fact, the observation of impaired morphology of spermatozoa in the cyclists has been previously reported, not only compared with the sedentary control subject, but also compared with the marathon runners, elite triathletes, and weightlifters. Sperm motility has also been shown to be lower in the cyclists and runners, and in the latter group was related to the training volume. And furthermore, a prospective study in overtraining endurance trained men resulted in 50% reduction in sperm count after 3 months, and however, all values remained within the normal range. So this is the proposed mechanism, the possible correlation between endurance sport with the possibility alteration in endocrine profile and also the seminological profile. So this is our last slide. Our summary is physical activity can impact reproductive function through its ability to regulate energy balance. Furthermore, the ability of exercise is to improve insulin sensitivity may prove to be an additionally important benefit for the women with PCOS. At both extremes of the energy spectrum, disorder of chronic energy excess and energy deficiency are characterized by a wide range of reproductive disorders, including menstrual irregularity, anovulation, PCOS, and infertility, and also erectile dysfunction and altered spermatogenesis in men. So, although laboratory research indicates that individuals may be able to prevent or reverse reproductive disruption either by increasing energy expenditure or by dietary reform in cases of energy deficit, there is acute need for applied research to confirm this idea and to identify mechanisms by which the availability of energy per se regulates the reproductive function in humans. So let's have a self-study session between among of you, because I was presented that some of the issue from 2010 and back. So you can also now start to dig in about the most recent issue and what is the impact about the exercise for health and the performance and its correlation with the reproductive function. So again, thank you for listening to this video. Have a good day. Assalamualaikum warahmatullahi wabarakatuh.